So much was discussed. If you don't remember the previous things, it is very difficult to go on. So much was discussed from this. It is highest in the kidney tissue compared to the heart. It is much higher. Although oxygen consumption is more, oxygen extraction is less, oxygen consumption is more. Everything was discussed. Now, if you can't, don't remember, don't try to remember by understanding, then you can't tackle the explain why is 5 marks will go, you will write anything over there. So if the theory paper is just for writing whatever I know, you won't get any credit. Forget about knowledge, you don't even prepare yourself for the exam. Like this, it will not, it can't go on. Most people are there for, many people are there for just attendance. If you haven't revised the previous class, you won't understand most things, many things. This is renal blood flow, this is autoregulation of renal blood flow, how the macula densa is responsible for sensing NaCl, and if it is less, if the reabsorption is less, then macula densa cells less NaCl, then how it is influencing JGA cells to increase more renin, that is TGF. And myogenic autoregulation also similar thing, renal blood flow it is increased. So how does the stretch of the wall stretch, how does it affect the contraction of vascular smooth muscle, so that again it can be, so these are all negative feedback methods, it can be normalized. This is about TGF and myogenic autoregulation, autoregulation of GFR and renal blood flow. This was also done. Now they are writing 1000 to 1250, that is more or less everything. Some authors are varying like this, but it is almost like that. 1000 you write this figure. This is in more standard textbook, this figure 1200 to 1300. Now, so what will be the plasma flow? What percentage of this? How much of blood is plasma? 55%. So 55%, if it is 1200, it comes to, so that is simple mathematics. Like this it will be 650 and 65, 650. So from this comes, we take it around to be, so books are writing it as 600 to 700. So how we will calculate it, but how we will get it from the clearance values? We are behind time because I had to revise clearance all over again after a gap of 1 week. I had to means if I do not, then it will be difficult, but if you don't come and study, if you are blank like this, then nobody has anything to do. So plasma flow, see, this will be 55%, 1000 it is 550, like this it will be there. So how to calculate it based on clearance? Like GFR can be calculated, estimated on the basis of clearance values of inulin and creatinine, we have discussed. Likewise, renal blood flow can be calculated on the basis of clearance of a substance called para-aminohippurate, because it is, first it has to be the criteria, one criteria, it clearance, GFR based on clearance and RBF based on clearance, one criteria is same. The kidney itself must not degrade or produce the substance. It must not produce, then the values will. So, if the kidneys itself does not degrade or produce, then only it is valid. Then what is entering the kidney through the renal artery can leave through whatever is entering through renal artery can leave through either renal vein or urine. Right? No other way of going out. Now you say it will be extravasation, blood vessels torn. We are talking of physiology. Physiologically, it cannot. If blood vessels are injured, then it can come out and remain in the tissue spaces. That is one possibility. But if physiologically, whatever goes in through the renal artery, whatever substances will come out, will get back into the blood through the renal vein, or it will go out through urine. These are the only possibilities. So Fick's principle is there, which you must have already, you must have known, you must know after cardiovascular system. Fick's principle says that mass will be balanced. Whatever output, input is equal to output, mass will be balanced. We measure cardiac output with the on the basis of Fick's principle. So amount of substance that flows into organ, it should flow out of the organ. By any organ, Fick's principle you should know. Now how to measure para-aminohippurate? How do we measure? No substance. We told clearance is a virtual volume of plasma. Now again, if you can't correlate this, it is very difficult. Clearance in a virtual volume of plasma, which is completely, this word completely is the keyword, completely cleared of a substance. This does not actually happen. Virtual means which is not real. In reality, what happens? Theoretically, we know the value 700 milliliter, 600 milliliter. This is cleared of a small amount of any substance, say X, any small amount of substance, X. So, but for defining clearance, for understanding the concept of clearance, we take it as a virtual volume which is completely cleared of a substance. Now, actually, if this real volume 700 ml, which we are speaking theoretically, but to estimate it, we don't know this value. We are estimating the renal blood flow on the basis of clearance. We try to, then this real value, if it is completely cleared of any substance, that only can estimate renal blood flow on the basis of clearance. Do you get it? Again, renal blood flow can be estimated on the basis of clearance only when we take it as a virtual volume completely cleared. But when we can calculate it on many substances. For inulin, it is GFR. Why? Because inulin is freely filtered. Inulin is whatever inulin is coming through the renal artery, then through the arterial branches, through the glomerular capillaries, it is freely filtered. Nothing is going into from the glomerular capillaries to the efferent arterioles. Nothing is going into the efferent arterioles. So it will be freely filtered. So in clearance and go out through urine. It will not be reabsorbed. So it will be freely filtered through the glomerular capillaries and go out through the tubules through urine. So nothing is reabsorbed. Plus obviously nothing is produced, nothing is degraded by the kidney, nothing is reabsorbed. So clearance can give the value of GFR. Likewise, to estimate renal blood flow, if that whole volume of blood which is coming, or that renal plasma flow, which whole volume of plasma, so clearance is the amount of plasma. Clearance is not the amount of substance by definition. So if that amount of plasma is actually cleared in one single flow through the kidneys, then only we can estimate renal clearance, renal plasma flow on the basis of clearance. One such substance is para-aminohippurate, only one such, and still it does not. It is wholly not 90% is fulfilling these criteria, 10% goes back to the renal veins, but still 10% is negligible. So we calculate it on the basis of renal plasma flow. Now what will be the equation as we had written for clearance? So what is going in through the arteries? Again mass balance equation. What is going into the arteries? pH concentration in renal artery. These abbreviations are not universal. If you use these things, concentration in third bracket, it is still accepted. But if you use these things like RA, I am writing, anybody may write anything else. So you have to explain this. In the side note, you have to, in the footnote, you have to explain this. What is RA? So pH is renal artery into renal plasma flow. Now here we are not taking the rate, there is no need. Total renal plasma flow, we are estimating renal plasma is equal to concentration of into renal plasma flow. If something goes out through the vein, first let us consider something goes out through the vein plus, sorry, so till now we have talked of rates of blood flow in the renal plasma artery. We are not talking of rate, we are considering the whole volume. UV is urinary volume. We had written something called V and dot above it, that is urine flow rate. Now here talking of the whole volume, because we are considering it 1 minute and the whole PAH is cleared in 1 minute. First let's consider something may go out through the renal vein. Now if we rearrange this, what will happen? If we rearrange this, we will rearrange this for RPF. So what will happen? This will come on this side. Now can I jump one step? Simple mathematics. RPF is urinary concentration of pH into urine volume Can you rearrange the equation and come to this? Very simple. This will come on this side with a subtraction sign, and for solving for RPF, this will be the equation. Right or no? Right or wrong? This is right. This is mathematics, just mathematics. Just rearranging the equation. This is the renal plasma flow. Okay? Can you get it? Do you get it? Or don't you get it? Don't you get even the equation? I have jumped only one step. Rearranging the equation and solving for renal plasma flow. Now what we are saying? Actually, renal veins, how much goes out through the renal veins? It is 90% goes out through the urine, but 10% through the renal veins. So it will be so whatever is the concentration in the renal artery, this concentration is 90% of that in the renal artery. Okay? So this is (90 by 100) is 0.9. This is, that means 9 by 10. That is, we should not. It is better to keep it in decimals mostly. Okay, to keep it in decimals. So it will be 110 by 100. That means 1/10. So this is the true renal plasma flow. Why we are calling it true? Because actually 10% goes out through the renal vein, right? So 90, this is the true renal plasma flow. But actually is what is happening. But this 10% if we ignore, then that equation becomes if we ignore that 10%, this equation becomes this. We ignore that concentration in the renal vein as on that is only 10%. So effective is just you divide this by this and multiply into 100. Effective is 90% of this is true renal plasma flow. Oh, I just did it wrong. It will be 9 by 10. I wrote it as 90 by 100, that should be 10 by 100, and you should correct me. That was a silly mistake. So Renal vein, where I substituted the renal vein by the concentration in the renal artery, it will not be 90 by 100, it will be 10 by 100, 10%, 10 by 100. So it will be 90 by 100, this true renal plasma flow. So that is 90% effective renal plasma flow is. So you should have corrected it, don't remain so blank. Everybody is human, can mistakes, you should have corrected it, and you just took down the wrong thing. That will, when I substitute concentration of PAH in renal vein on the basis of the value of the renal artery, it will be 1/10, because 10% goes out through the renal vein. So if we divide this by this, ERPF by TRPF into 100, that is how much percentage is effective renal plasma flow of true renal plasma flow, it will come to 90%. Just divide this by this, right? It will 90%. So effective renal plasma flow, if it is, you will be given in problems, mathematical problems in the OSPI part, you will get these problems. The values will be given, these values will be given. Okay. Now one thing is that you have to measure urinary samples. These values will be given though. Practically these are measurable in laboratory, these will be given. This is simply written as PAH because the body tissues don't absorb PAH. Okay, PAH is a substance which is usually not produced in the body, so it has to be injected, and the body tissues, the muscles and all, everything, nothing absorbs it. So concentration in renal artery is as good as concentration in any peripheral vein. So practically we have to take urine sample and urine concentration we have to measure. Urine volume is measured by, or urine volume rate is measured by something called uroflowmetry. We will discuss this. We have options to discuss. That means it is, we have to discuss this in short in this physiology classes only. But uroflowmetry, we will learn more about this later also, but you have to discuss this. Uroflowmetry. So concentration of urine in urine you have to measure in the laboratory, concentration of pH, concentration of pH. In the renal artery, it is difficult, somewhat difficult. So if we take from any peripheral vein, why it matches the concentration in renal artery? Because extraction by body tissues is very negligible. Okay, so this is the equation. So 90% of this. So any in the OSPI, whenever you are solving the problem in the SP from the examination point of view, if you are solving, if it is given concentration of pH in peripheral vein is this, or say it will be written concentration of pH in antecubital vein, which is the peripheral vein from which blood is preferably collected, that is the antecubital vein. So that is from there, if it is taken, it will be given in the question from the antecubital vein. So here you can find the renal artery, but it matches that of the renal artery. So that you have to know, right? So we expect that without writing, so I took 10-12 minutes for it. We expect that the slide is over there, same thing is written, you will understand just by reading that. But I do not have that faith on you, so I did it. And it is taking a lot of time. If you remain blank when I am just writing simple mathematical equations, then it is. And again, see, from renal plasma flow, from the opposite side, theoretically we are calculating 55% of blood flow is plasma flow. Now if you do the opposite, renal plasma flow, if you have got, it is 55% of the blood flow. So the total blood flow will be something like that. Renal 1 minus hematocrit means hematocrit is 45%. Hematocrit is 0.45. So 1 minus 0.45, you will divide renal plasma flow by 1 minus 0.45, that is 0.55. Then we get the renal blood flow, obviously. So 10% in renal vein, ignore those things are written. So same things. This is the same thing. How will, I mentioned last day, Remember, inulin and creatinine will be freely filtered in the glomerulus, but pH is no. pH will go out through urine, but only 20% of renal blood flow is GFR. Most of it 20%. So only a little pH. See, out of 60 milligram per minute, 12 milligram per minute, that is the filtered load. Filtered load is in milligram per minute or maybe in millimole per minute. So unit of mass and in unit time. So that goes out through filtration, but rest is, the criteria is not like inulin. In inulin, everything will go out through filtration, but in pH, some goes out through filtration, rest goes out through, whole goes out through urine, only 20% or something, so rest 80% by secretion. Now one point to notice, secretory capacity also, we will discuss reabsorption and secretion and we must do it today. This is high time, but reabsorption and secretion, one point is, secretory capacity has a maximum limit. So if we inject too much of pH, then all of it will know, again the calculation will go haywire. If we inject too much of pH, the secretory capacity means the here, the secretion from the peritubular capillaries into the, so everything is not shown in, it is shown, this is the renal tubule. Whatever part of the renal tubule, there are reabsorption or secretion of different substances in different parts of the tubules. So simply take it, in one part of renal tubule, 1 or 2 parts pH will be secreted. So this secretion has a maximum capacity, because secretion and reabsorption are dependent on transport proteins and all, or diffusion capacity. Those have limits. So if we inject too much pH, everything can't be secreted. Then instead of 10%, maybe 30%, 40% will go into the renal veins. Then the calculation again becomes difficult. That means it does not follow by the law of mass. So it is again difficult to take a sample from renal vein itself and calculate. So it will not be possible. So we should inject. There are measured amounts of pH. That is experimentally. That is, we have decided that how much pH to inject. It should not cross a certain limit. So then only everything again will be going to the blood. And renal vein. See, it is writing 0 milligram per minute. But actually, even if it is very less, it is 10%. So it is 60 milligram, it will actually 5 to 6 milligram will actually go out. But that is neglected. But if it is more than that, if it is 20 milligram, 1/3, then it is, then the calculation, these calculations will not hold, whatever we wrote on the board. So this is again clearance of, see, this is simple, clearance may vary between 0, after all this discussion. Glucose never goes out through urine under physiological circumstances, so clearance is 0. Clearance is the whole of the renal plasma. If it is pH, clearance is the GFR if it is inulin. That is what is written over here. And again, see, at low plasma pH, in the point B, low plasma pH concentration, clearance equals of pH renal plasma flow. If it is high, then everything it will exceed the secretory capacity, so that cannot give. If it is very high concentrations of pH. Okay. Para-aminohippurate or para-aminohippuric acid. Now this is not exactly of something from renal physiology. Just look at nothing to some a few numericals you may have to remember, or you come across physiology a lot of times. What are the extracellular, intracellular and plasma concentrations of substances? Potassium is mostly intracellular, sodium is mostly interstitial, or this is, sorry, there is one line over there. So plasma concentration, interstitial, intracellular. Interstitial means tissue spaces and within the plasma. So potassium is mostly extracellular. We may refer to these things. We'll come back when in the course of the discussion. We may come back to this slide just for seeing the values. You don't have to remember all values, but some values like sodium is actually 135 to 145. It should be a range, not a single value. Okay, like this. And milliosmoles and millimoles can be calculated if we know the concepts of osmolality, equivalence, molar mass, all these things from chemistry, knowledge of chemistry. We can do that. and that you should do by we all should do by ourselves. If we know the molar mass and all, then we should calculate. Now, reabsorption and secretion, what are the basic things to remember basic things to know? See, this is a proximal tubular cell, any tubular cell, proximal tubular cell. So, how can substances be reabsorbed? Either across the cell or in between the cells. Across the cells is called transcellular movement. Transcellular movement. Now, just I mentioned just one line. What is trans? The meaning of the word trans. Whenever we are speaking of a value like transpleural pressure, it is inside minus outside. Transpleural is intrapleural minus inside pressure minus outside pressure. It can be pleural or anything. But here movement is trans means across. So transcellular movement or paracellular movement is in between the cells. There is some gap. What are there in between the cells? Is it so much large? It is just for depiction. What are there? What are their junctions? What are the names of the junctions? What are the names of the intracellular communication? Tight junction, gap junction. So here, these are desmosomes. Short notes. Just see the 10 years, 15 years question paper. Otherwise, at least 5 years. 5 years, 10 years question papers. If you don't follow from this is high time. More than gaining knowledge, you have to just pass the exam right now. If you don't review it, tight junctions, gap junctions, desmosomes, semidesmosomes, these were discussed in initial classes in November, I think. So there are tight junctions, so they in between the cells. So paracellular route, that is the paracellular, simple diffusion through the tight junctions. And there the paracellular path. See, there is something called bulk flow. Bulk flow means solvent is going, diffusing, and solutes are dragged with it. That phenomenon is called solvent drag. Solvent is diffusing, solutes dragged with it. That is called solvent drag. Right? Paracellular, transcellular. When I am telling the word right, that means you should have solvent drag. You are not expected to listen before. But some things you have to know. How can the substances pass transcellularly? How can they be passed transcellularly? Will it just diffuse? It is the only way. So if it has to do against concentration gradient, how will it do? Please speak. How will it do against concentration gradient? It will require energy. Who will provide the energy? What can provide the energy? Obviously ATP. মানে কতজন বসে আছে জানি না 4 1 2 3 4 5 6 7 60 people maybe 60 70 maximum 60 people 70 like this. So 70 জনের মধ্যে একজন তাও বিড়বিড় করে মুখ খুলছে, মানে আমি যেটুকু দেখতে পাচ্ছি যে ATP এনার্জিটা দেবে। There is something called the sodium potassium ATPase, এগুলো আছে তো। So that is a sodium potassium ATPase is a pump. So what can drive the substances transcellularly? Either reabsorb or secrete. Reabsorption will be from the luminal side of the transcellular cell, tubular cell, through certain things. Whatever, sodium, according to concentration, it will require energy, sodium, glucose, anything that is reabsorbed or anything that is secreted. এই যে pH, toxins, কিডনির কাজ কি? ওয়েস্ট ম্যাটেরিয়ালস বাইরে বার করে দেওয়া। টক্সিনস যাই রিঅ্যাবজর্বড হোক, টক্সিনস উইল নেভার বি রিঅ্যাবজর্বড, ইট উইল বি সিক্রিটেড। সবকিছু টক্সিনস, প্রোটিনস, বড় প্রোটিন পারবে ফিল্টার্ড হতে পারবে না, ইট ক্যানট বি ফিল্টার্ড, ইট উইল বি whatever will go out through urine has to be secreted. Proteins এর কথা বলছি না, টক্সিনস, anions, that can be anion in anionic form, organic anions, organic cations, এগুলো যাই থাক, they will be secreted. If it is to be done against against gradient, it will require energy, or it will be through diffusion. Diffusion by itself is, sometimes it is possible that it will diffuse itself across the cell membrane, but sometimes it requires some proteins, that is called facilitated diffusion. and sometimes it is through channels like ion channels. If potassium goes through a channel, that is ion channels. Sometimes it is through proteins but two substances together, that is called in the same direction symport, in the opposite direction it is antiport. So that is what is over shown in here. So these red lines are transport against a concentration gradient, that is say sodium potassium ATP, that is transport, no, that is not the perfect, that is a pump. So that is a pump, sodium potassium ATPase. Against concentration gradient, energy has to come from somewhere. Mostly it is ATP in living animal cells. Sodium hydrogen antiport, sodium glucose symport. Symport is same direction. This is example of active transport, primary or secondary. Transport of glucose is secondary active transport, example of secondary active transport. So at the end of towards the end of the session, if you don't correlate with other parts of physiology, it will become again you have to memorize everything. It is not humanly possible. 3 subjects in 9-10 months if you don't correlate. And these are the peritubular capillaries on this side. This should be in red, this is shown in pink. So reabsorbed, this is the lumen, this is reabsorbed and going into the blood on the basal. So this is the apical membrane. Come back to the previous one. So this is the tubular cell. If this is the tubular lumen, this is the apical membrane. See, there are invaginations. Whatever we spoke of when we spoke about the renal anatomy, basic anatomy. So there are invaginations, there are cristae, there are lot of mitochondria in the proximal tubule. Again, more or less same things they are showing. Co-transport is sodium and glucose together, SGLT. This is the sodium glucose co-transporter, SGLT, GLUT, GLUT. There are various forms of it, GLUT1, GLUT2, GLUT3, GLUT4. GLUT also, insulin glucose is coming into the cells in the body under the action of insulin. That is also GLUT, GLUT4, GLUT3, GLUT2, GLUT1. All these things are proteins which are helping in facilitated diffusion. NHE is NHE. Don't remember the full forms of all things. NHE is one of the sodium hydrogen antiporters. Amino acids will go, not only glucose, amino acids will be co-transported with sodium. Okay, the name of the protein is not given. So these are examples. These are just the examples. From the luminal side, it will be absorbed to the interstitial fluid. It will go to the interstitial fluid and then it will go into the peritubular capillaries. Reabsorption of water and sodium is most in the proximal tubule. Almost, this is whatever values are given here. Standard textbooks are writing 65, 67, almost 70% of sodium and water is reabsorbed in the proximal tubule. And how much glucose in the proximal tubule? Theoretically 100%. Everything, whatever glucose comes physiologically will be reabsorbed in the proximal tubule itself. Okay? And then in the loop of Henle. So this is the proximal convoluted, then proximal straight, then thin descending limb, thin ascending limb, thick ascending limb, distal convoluted tubule, and that will be divided for the sake of discussion of this reabsorption. That will be divided into early part of distal tubule, late part, because in the early part it is impermeable to water. Like remember, thin, these things you have to just keep in mind. Reading repeatedly, you have to keep in mind which parts are impermeable to what and permeable. This thin descending limb, it is permeable to water, but thick limb, this thin ascending and thick ascending limbs are impermeable to, yes, this is impermeable to early distal convoluted tubule, this is thin descending limb permeable to water, but these parts are impermeable to water, like this. Okay. So we will come back to this. So glucose is 100%, amino acids, most of amino acids, almost all, practically all in the proximal tubule itself, it will be reabsorbed. Okay. At the end of the PCD, tubular fluid will be isotonic. We will discuss these things again. So first you see the reabsorption and secretion part. Again, this is the thing we will again discuss later. This is the thing. See, water in the ascending limbs, water, it is impermeable to water. How is water reabsorbed? Through the aquaporine. Water reabsorption is through aquaporins. Those proteins, those are the carriers for water. Water can diffuse, obviously it can diffuse, but sometimes most of it requires proteins also. In the thick ascending limb is such that permeability to everything is zero. Permeability, that is diffusion, but active NaCl transport is possible. Active NaCl transport means through the sodium potassium ATPase pump. Whatever is, these are the values. Values are not important so much, but see, this is just depicting filtered road reabsorbed. So everything about mouse to sort out. Water 180 liters of day filtered per day, 180 liters, 125 ml per minute into 24 hours means 24 into 60 minutes, 180 liters per day, most of it is. So 1.5 liters is the average volume of urine. Sodium, it is in milliequivalents now. Most of the filtered road is reabsorbed. Glucose, see, 100% is reabsorbed. 800 is in, this is in millimole. So we have to calculate it from molar mass, again from the knowledge of chemistry. What is C6H12O6? Glucose. So it comes to molar mass will be 180. Just calculate it. Carbon is 12, water is 1, hydrogen is 1, oxygen is 16 atomic weights. So molar mass of glucose will be 180. So 180 milligram, 800 millimole. That is calculation. But all these 100% of glucose is reabsorbed. 99%, 100%, almost 100% of sodium, water. All these are just values. You don't have to remember the values. Urea, 50% is reabsorbed, not all. Okay. Now this is actual how the reabsorption, the proteins and all. See, sodium, we have already spoken, sodium, hydrogen antipode. This is the first part of the proximal tubule. First part of the proximal tubule. First half, or you may say first half. So what is going in? Sodium is reabsorbed, and on the basolateral membrane there is sodium potassium ATPase, which is maintaining low intracellular sodium concentration so that sodium can be reabsorbed from the tubular lumen. What is getting into the cell? Potassium. Again, some potassium is going out through potassium channels. And how it is balanced? By where from the hydrogen is coming? Inside the cell by carbon dioxide is there inside the cell, combining with water, hydrogen ions and bicarbonate ions are formed. Bicarbonate ions and sodium, again these are also like sodium, potassium. What is the role of sodium potassium ATPase here? Maintaining intracellular low sodium. But reabsorbed sodium is going out through that pathway. We may also take, there is a part, but sodium and HCO3, that is bicarbonate, are going out together. That is sympode or antipode. Same direction or opposite direction, just look there. Same or opposite, same direction. The protein is NBC1. You don't have to remember the values. You just draw, when you draw, you just draw right protein or right symporter. Sodium, hydrogen, sodium bicarbonate symporter. You don't have to remember the names, all the names. These are from the standard textbooks of physiology. So you don't have to remember NBC1 always. Sometimes it appears in MCQs, but those are difficult for you. So some examples you have to remember, like SGLT is very common, a common name. But if you can't remember NBC1, write sodium bicarbonate symporter in the basolateral membrane. This is the tubular lumen side. This is the peritubular capillary side. That means the interstitial side. And this space between the blood and the cell, small space obviously, not, this is depicted as large in the picture. This is small space. This is called the lateral intercellular space. Lateral intercellular spaces. So see, this is the first part, sodium, glucose. The protein is SGLT2, you should remember, because in medicine you will learn SGLT2 inhibitors, pharmacology, not only medicine. Next, when you read the drugs, SGLT2 inhibitors for diabetes mellitus. So glucose reabsorption, it is SGLT2 inhibitors, then glucose will not be reabsorbed. Most of the glucose is reabsorbed in the proximal tubule through SGLT2 SGLT2. This is the This is a example of secondary active transport. And again GLUT2 example of glucose is going out into the lateral intercellular space, example of facilitated diffusion. It cannot diffuse directly, it has to be facilitated by a protein. Okay, diffusion does not require energy. Okay, so this is in the first half. Now what is not shown here, along with glucose, like sodium glucose importer is there, sodium amino acids importer is there, which we showed in here. These things are also there, not shown there, but amino acids can also be transported like that. So what is not reabsorbed in the first part, very less reabsorption, is chloride. So what is this depicting? This is the tubular fluid concentration. It is showing against the distance along proximal tubule. Along the first half of the proximal tubule, what happens? First half will be like 50-60%. All these substances, phosphate, bicarbonate, glucose, all these are reabsorbed more than water. Very large reabsorption. So what is happening? Concentration is decreasing. Sodium is at par with water, but chloride is very less reabsorbed in the first half of the proximal tubule. So chloride, tubular concentration of chloride is increasing. Okay, chloride, tubular concentration of chloride is increasing as it is very less reabsorbed in the first half of the proximal tubule. Where it is then reabsorbed? It is reabsorbed in the second half. Chloride is exchanged with base. Base means any base, formalate, oxalate, bicarbonate. Bicarbonate is the commonest, you know, most spoken of. So chloride base, any base it may be, and that protein is called antiporter. Antiporter, it will be antiporter opposite direction. So it is named CFEX. If you don't remember name, write chloride base antiporter. Again sodium hydrogen antiporter, NaHe3 here. Here it was NaHe3. Sometimes it is NaHe1, NaHe3. If you don't remember the name, write sodium hydrogen antiporter. So sodium is going in and hydrogen base both are coming out and combining again in the lumen into hydrogen base, and this is recycling. Okay, and tubular fluid, what is showing here, this is sodium potassium ATPase, like in the first half. Chloride is going out through channels, chloride is reabsorbed where, and now how it is reabsorbed from the basolateral membrane? Through chloride channels or along with potassium. So that is potassium chloride symport, what is written as KCC. If you don't remember, write potassium chloride symporter. Just give the arrows and write potassium chloride symporter, written as KCC. Right. So this is how it is going out, and some again as the concentrations are varying, what is happening? This, what is this type of diffusion? This is sodium and chloride, both sodium and chloride between the cells. This is transcellular or paracellular. Just now we discussed what is the difference between transcellular will be across the cell. This is paracellular, in between the tight junctions. This one, this arrow, paracellular diffusion through the tight junctions. So sodium water reabsorption comes as a question. This is water. Water reabsorption will be transcellular. AQP proteins are not labeled either by simple diffusion or by the process or by ACP. This is along the proximal tubule, along with sodium, water, AQP. Osmolarity will vary, but it is seen that osmolarity of tubular fluid lumen and lateral intercellular spaces, their variance is very less. 287 and 293 is almost similar, only little osmolarity difference. Again, there is difference between osmolarity and osmolality. Take note of that. What is osmolarity and osmolality? Something is in kg of solvent and something is in liters of solution. Just go through osmolarity and osmolality difference again from general physiology. So everything, if I have to mention here in renal physiology class, renal physiology can't be completed. So again osmolality, but differences will be similar. Osmolality, little, actual difference is little, but the theoretically definition is varying. So solutes, these solutes will be dragged along with solvent, we were speaking of solvent drag, and water is going out both by transcellular route and paracellular route. Proteins involved are aqua proteins, AQP1, AQP2, AQP3, till date 13 have been identified. Okay. In the proximal tubule, mostly it is AQP1. These two pictures are combined, they are showing the transport of organic anions and organic cations. Okay. Organic anions and cations. What are anions and cations? What are anions and cations? Anions are positive or negative charges, negatively charged particles. Organic means that will carbon atoms, organic, so carbon rings. So you don't have to remember all the names. See, OAT 1, 2, 3, these are proteins. These may be OAT 1. So intracellularly, what is intracellular? It is negative or positive? Negative. So organic anions has to be, are these reabsorbed or secreted? Organic anions or cations are toxins, drugs which are not required, drug metabolites. All these will not be reabsorbed, all these will be secreted. So this will be go from the basolateral membrane into the lumen. So anions will be secreted against concentration gradient. And this is alpha ketoglutarate. Alpha ketoglutarate, and sodium is sodium alpha ketoglutarate, symporter, OAT, alpha ketoglutarate antiporter. And on the luminal side, OAT4. OAT4 is responsible for one of the organic anions is urea. Okay, urate. So OAT4 is responsible for secretion of urea. Secretion is coming through basolateral side and going into the luminal side. All these you don't have to remember the names. These are only proteins, just label as proteins. Okay, antiporters or symporters. But for cations, it does not require energy. Here it will require energy. Sodium alpha group, all these symport and antiport are requiring energy. Here will it require energy? Cations will just diffuse because intracellular it is negative, and then it will go out. There it will require energy. Why during going out it will require energy? Because again, because of electrochemical gradient. This is provided by ATP, ADP. You don't have to remember MDR1. You just label them as proteins. Okay. These are some endogenous anions like bile salts, urate. This is an extensive list, not an extensive, this is a short list, but you don't have to remember all. But this urate, oxalate, all these things, bile salts are anions. But creatinine, dopamine, and all those dopamine, epinephrine, norepinephrine are, what are they? Catecholamines. Those are cations, and there may be drugs. We will continue with, it is better not to discuss we will continue with the reabsorption and secretion in the last part, distal tubule and all, in the next class, along with the reabsorption and secretion in the collecting ducts. Principal cells and intercalated cells are there. Again, I would suggest that you read that part. What are there? Principal cells, intercalated cells, all these cells are there in the last parts, collecting ducts and all. So those parts, collecting tubules, collecting ducts. So to continue the discussion.